Good morning. I guess we can chit chat for a couple minutes before we start, David. If anyone wants to say hello.
Morning, everyone.
Hello. Good morning, everyone.
Hi,
Morning,
good morning.
Good morning.
Good morning, everyone.
I know for David, it's late at night there. How about you, Rashmi? What time is it in Italy?
It's only 4 o'clock in the afternoon, so it's a good timing. But it's
Robin,
really
are you
hot.
on East Coast time or are you in Central? Robin Mitchell.
Oh, I'm sorry. Yeah, we're in Michigan, so it's Eastern Daylight Time.
Okay, same as here.
It's 10 o'clock. 10 o'clock in the morning.
Good morning,
I just
Hannah.
discovered the difference between Eastern Daylight Time and Eastern Standard Time yesterday.
And he educated all of us. I didn't even know there was a difference, really. And that it affected things like this, meetings like this.
Yeah, well, in Australia, we don't have daylight savings. I have heard of the concept, but it threw me off.
I think they're talking about getting rid of it because it's more of a nuisance than anything.
Yes.
Yeah,
Yes.
yeah. I think we trialed it when I was a teenager, and I think it was, it was like a census thing, and it was 90% no.
Yeah. Yeah. It's so pain. Oh, there's Giorgio. Hello, good afternoon, Giorgio.
Hi. How you doing?
Yes,
So you cannot talk anymore.
Kash, I'm just looking through the list. The one speaker that we don't have yet is Veronica.
correct. And Sanath is going to join at some point, right?
Yes, yeah. So he said that he'll be on by about 10:15.
Okay, I'll text Veronica. Oh, there's Ann. Good morning, Ann.
I saw Anne put something in the chat
Yeah,
function.
she's in her car.
Yeah.
Oh, gotcha.
Good morning, everybody. Just wanted to say hi. I'll be in
Yeah.
the car with the kids, but I couldn't help but want to pop in and say hi and see everybody's faces and hear voices.
Awesome.
It's awesome. Good to hear
I
your
hope
voice.
they're off on some fun adventure.
Yeah, it's always fun with the kids. Thanks.
Awesome. Veronica is on her way. So when Veronica joins us, we can get started.
Awesome. I went to an indoor playground with my kids. It was for a birthday today.
Oh, whose
You
birthday?
have those in the States, like the big indoor playgrounds where everything's padded.
A lot of the McDonald's have them. But
Oh, yeah.
other than that, not really.
These
Not around
things on
here.
like a very big scale. You probably have, the playground could hold like 300 kids.
Oh, wow, no.
And they go up like several stories. And it is the noisiest experience I've ever been through.
Sensory overload.
I can
It's a
imagine
wild
that
ride.
place was a no-no during COVID.
Yes, there was actually a lot of them that shut down
Yeah.
in COVID. We have a lot of them in Western Australia. I don't know why, but they're good. but it's a 2-hour limit and every adult goes crazy if you stay for longer than 2 hours.
Let me know when you see Veronica. Mhm. Not too many kids on. I saw Sebi there for a second and Hannah.
Hannah's there.
Oh, there's Hannah. Oh, she's got a beautiful teddy bear. Oh, look at that hug. So cute.
You say hi.
Hi. I love your smile.
How old are you, Hannah?
27.
27.
She's a young woman. And there's Sebi. Hi, Sebi.
My daughter would love that teddy bear.
All right. Shall we get started?
Sure.
Oh, and there's Sub.
Okay. Welcome everyone to T2T or TANGO2 Talk. Every few months, we plan to hold events like this so that we can stay connected, see each other's faces, and stay informed. More and more is being learned about TANGO2, and we want to make sure that you hear about it. And we also want to hear from you. My name is David Longman, and I am a dad to Erling here in Perth, Western Australia. I am currently a member of the Foundation's board. I have recently assumed the role as chairperson of the Outreach Committee for the TANGO2 Research Foundation, taking over from Blake Moore, who provided leadership in this position for the last 3 years. On behalf of the Outreach Committee, I thank Blake for his efforts and his contributions. The mission of this committee is to spread awareness, share information, and make connections between families, the community, the foundation, and the scientific and medical community. These TANGO2 talks are just one way we can do this. So I'm really glad to have you all here. This talk is coming at a perfect time because there is so much to share with you all. For the next 45 minutes or so, you will hear highlights from the conference, an update about the natural history study, a recap on the Shine a Light on TANGO2 fundraising event, and we also have a guest speaker, that is Sanath, Kumar, Ramesh, joining us today. To get us started, we have Marcy with a big announcement. Marcy.
Hello, everyone. As you know, I'm Maricela Lopez. I'm mom to Sammy. Y'all know that you are like family to me. And today I have the pleasure of introducing a new member to our TANGO2 family. On July 11th, Dina Chisholm joined the TANGO2 team as our new Research Engagement Director. Prior to joining the TANGO2 Research Foundation, Dina spent over a decade with large, complex healthcare systems and nonprofit organizations developing and leading research and public health education initiatives. She is experienced in developing and implementing community health education, tools, programs, and interventions that promote engagement, optimal health, and wellness. Dina is skilled in grant, program, and project management, multivariate statistical analysis, qualitative research methods, and community-based participatory research, or CBPR. She holds a master's in public health from Westchester University. Additionally, she was inducted into the Beta Psi chapter of the Delta Omega Honorary Society of Public Health and became certified as a health education specialist by the National Commission for Health Education Credentialing. Dina currently resides in Delaware with her husband and 2 children. In her free time, she enjoys taking fitness classes like cardio, kickboxing, and spin, exploring new restaurants, traveling, and reading. It is my pleasure to introduce Dina Chisholm.
Good morning, everybody. Marcy, thank you. What a wonderful introduction. And what a pleasure it is to meet everybody. I'm really grateful to be associated with such a great organization. Thank you all so much for making me feel comfortable and appreciated this first couple of weeks. I hope that we can together take TANGO2 Research Foundation to new heights. I'm really looking forward to working with all of you and learning more from each of you as well. At this time, I'm going to go ahead and turn it over to Veronica Jones. Veronica is going to share some highlights from the recent TANGO2 Family Conference. Veronica?
Hi, everyone. So as you know, the second TANGO2 conference was held in Orlando at the end of June, thanks to the grant we received from the Chan Zuckerberg Initiative. And there were over 100 people, including 20 international families that joined us for this 2.5-day event. The first night we gathered for the informal meet and greet, just so we could have some time to meet and say hello to each other. And it definitely felt like a family reunion, even with people I was meeting for the first time. Then for the next 2 days, we were able to hear from more than 12 different speakers, all on the topic of TANGO2 and everything that we're learning. And then we also had an amazing keynote speaker, Chris Nick, who's a 22-year-old with Down syndrome, and he completed an Ironman competition by working hard to be 1% better than the day before. And if you'd like to find out more about his inspirational story, he has a book available called 1% Better, Reaching My Full Potential and How You Can Too. You can email Anne to request access to their presentation too. Her email is just ann.geffen@tango2research.org. And then we also had speakers about many TANGO2 topics, including the basic genetics of TANGO2 with very parent-friendly explanations, mitochondrial dysfunction in TANGO2, metabolic studies of TANGO2, cardiac crisis, including what has been working best in correcting heart complications in TANGO2 crisis, fruit fly studies to better understand TANGO2, heart cell research on TANGO2, and we heard how families are helping to save lives through the NHS and that there are strong indications that B vitamins are helpful for those with TANGO2 to avoid crisis. In addition to speakers, we also had group discussions on what matters most to families, educational issues, nutrition and diet, and parenting tips. There was a sibling session, a Shine a Light celebration party, and many, many opportunities for families to connect and get to know each other at meals or by the pool. I can't wait for the next one in 2024 when we can gather together again and hear more progress in understanding TANGO2. And then finally, I'm happy to announce that most of the conference presentations are now available on the TANGO2 Research Foundation YouTube channel for you to view. And you can also encourage any interested professionals that work with your children to subscribe to the foundation channel and access the videos. So thank you. Next up, we have Lisa Wilson with an important announcement about the natural history study. Lisa?
There we go. Hello, everyone. I'm Lisa Wilson, mom to Tyler, who is 22. We are from upstate New York. Can everybody hear me? Okay, perfect.
Yes, we can hear you.
my internet was fucked up. We're from upstate New York. Most of you have probably heard about the TANGO2 natural history study that has been going on for the past 3 years at Baylor College of Medicine. Researchers there have been hard at work collecting information about TANGO2 from the experts, you. They have interviewed over 80 different families from all over the world, listening to their stories, asking questions, collecting data, and medical records. Then this information is studied and analyzed. They look for patterns in our stories that can help us better understand TANGO2. The information from the study is what helps create the emergency protocol letter that is used by many of us in the times of illness with our children. Excuse me. You have heard from Veronica some of the highlights that were shared at the conference about managing heart emergencies and the importance of the B vitamins in avoiding metabolic crisis. These important and life-saving findings came from all of us through the participation in the natural history study. So thank you for being part of it. And if you have any questions about getting started in it, please pop a note in the chat box below so that someone can follow up with you. But I also have an important new announcement about the natural history study for those that are already part of it. Multiple amendments have been added that will require everyone to re-consent or re-sign a document, giving permission to participate. By re-consenting, you'll have the option to share video recordings of some of our episodic TANGO2 symptoms. We have all been in the situation where our children have these strange episodes and spells, that symptoms that seem to disappear by the time we get to the doctors. Or we've all felt that frustration of trying to explain these quirky episodes to someone over the phone. Sharing these videos as part of the natural history study can help change that. Medical experts will review them and give them a consistent medical name like ataxia or paroxysmal torticollis, and etc. If we can better identify and name these symptoms, it might help pediatricians and neurologists diagnose TANGO2 earlier before any crisis. The sharing of videos is completely optional. Another addition to the natural history study is the addition of a questionnaire about development that will be repeated at irregular intervals so that there can be a better understanding of TANGO2 progression over time. And many of us filled out these questionnaires with the doctors on site at the conference. There is also the option to do a collection of a detailed diet history to understand the role of diet and nutrition for our children and the vitamins in preventing metabolic and cardiac crisis. And at the conference, families had the option to have a saliva sample taken for DNA sampling. Each of these amendments to the natural history study is optional. You can pick which ones you agree to, even if you don't want to do any of these, but you still be asked to re-sign so that you can continue to participate in the original part of the natural history study. So you need to make sure you re-sign and re-consent. So let's continue to work together to better understand TANGO2. In the chat box, you can find the email address where you can join the natural history study for the first time or request the document to re-consent. The email is tango2.research@bcm.edu. This can also be found on the homepage of the TANGO2 Research Foundation website. So thank you. Now, here is Amy Clay to share an update on the Shine a Light on TANGO2 campaign. Amy?
Thanks, Lisa. Hi, everyone. I'm Amy Clay. I'm mom to Kate, and we are also in upstate New York, just a couple hours from Lisa. In addition to being a member of the outreach committee, I'm also a volunteer on the TANGO2 Research Foundation fundraising committee. Back in February, a number of you probably, hopefully participated, but we, on Rare Disease Day, relaunched our second Shine a Light on TANGO2 fundraising campaign. During the first year, we raised an amazing $80,000. So we challenged ourselves this year to reach $100,000. I'm happy to report that we were able to reach $90,000. We had 16 teams from 5 different countries that participated. Teams showed a lot of creativity in the ways to raise money for TANGO2. We had people that did craft days with children. We did bottle drives, dinners, not only planned formal dinners, but also dinners with restaurants that just donate funds back to the foundation. We had mini golf tournaments, road races, raffles, all different kinds of things to raise money. Although the Shine the Light on TANGO2 campaign runs from February to June, any day is a good day to raise funds for TANGO2. Did you know that the TANGO2 Research Foundation has given away over $600,000 in research grants in the past 3 years? The money raised is being put to good use. It's being used to learn more about TANGO2 so that our children can have a better quality of life and a long future. Please keep the TANGO2 Research Foundation in mind for monthly giving, corporate matching, Facebook birthday fundraising, or any number of ways that can help to continue to raise money and fund additional research projects in the future. Thank you. Now I'll go back to David, who will introduce our guest speaker. David?
It is my pleasure to introduce Sanath Kumar Ramesh. Sanath is the father of a nearly 4-year-old boy named Raghav. Raghav was diagnosed with an ultra-rare genetic condition called GPX4 deficiency shortly after he was born. And this is where Sanath's story as a rare disease advocate, leader, and champion begins. Sanath has worked tirelessly in raising funds, awareness, and developing new pathways to treatment for his son's rare disease. This has taken the form of starting a non-profit charity called Cure GPX4, developing an incredible podcast series called Raising Rare, I really recommend it, and most recently establishing an open source non-profit software platform called Open Treatments. This platform aims to help rare disease communities research, develop, and access drug treatments, and does so by decentralizing drug development. I welcome Sanath.
Thanks for the introduction, David. Thank you so much for having me here. It's great to present my story to you all. And also, it was great to hear about your progress with fundraising and natural history and everything else. And it's just exciting and inspiring to hear your natural history has been going on for 3 years, and that is just invaluable data that hopefully will help with research at the end of the day. So I'll take maybe 10 minutes to present my story, and I will open it up for questions. I'm happy to talk on any topic if you have questions about my story, if you have questions about general drug development or the general ecosystem of drug development overall. Can I get sharing rights so I can share my screen? Okay, cool, got it. As David said, I'm Sanath Kumar Ramesh. I'm the proud father of this charming little 4-year-old boy. He is turning 4 in 2 days, so we're super excited. But when he was born, we realized right away at birth that there was something wrong with him. He did not, move his hands or body like all the other kids do. He could not take anything by mouth when he was born. So he had a NG tube going down his nose to continue to feed him. And through the next, 21 days he spent in the hospital, we were trying to find a diagnosis for him and did not actually have any success at all. It took us about 1 year on his first birthday for us to actually really find his diagnosis. As I was getting ready to cut the cake, I got a phone call from Raghav's doctor. She said, we think Raghav has this ultra rare genetic disease called SSMD, but unfortunately, we know nothing of this disease because all the other kids with this condition passed away a few weeks after birth. And Raghav is lucky to be alive today. I'm standing at my son's first birthday party, first of many to come, and someone is telling me that he is lucky to be alive. And so this was the starting point for everything in my life. It changed personally who I am. It changed what our family focuses on, and it gave us a mission and a purpose for our life. Raghav has a typo in his genetic code. There is a gene called GPX4, which is responsible for the reactive oxygen species control at certain part of the cell. And for him, a character G is mistyped as the character A in his gene. After we learned of this diagnosis, I personally thought, well, in this day and age of modern science and genetics and biotechnology, there should be some treatments available for him somewhere in part of the world. We are at a point where we can send civilians to space successfully and bring them back. We should be having some treatments for these diseases. Otherwise, what are we funding the science for, right? And so I cold emailed hundreds of doctors, researchers, scientists, biotech companies, sometimes even the FDA, asking for treatments. And guess how many treatments I found? 0. It's a story that you all are incredibly familiar with, but unfortunately, it turns out there are currently no treatments, and there will likely be no treatments in the future too. And this was the puzzling part for me, because the biotech industry is nearly a $1 trillion industry, but there is not even a single dollar available to create a treatment for my son. In fact, if there was a wait list for new treatments to be created, my son would be last on the wait list. You know why? Because Raghav's disease is what is called a market failure. The cost of developing treatments can be between $50 million to $1 billion. But unfortunately, with just 10 patients worldwide, companies won't make enough profit by building a treatment for my son's disease. You need at least a few hundred or 1,000 patients to have a profitable drug development venture. The current number from my conversations with the biotech industry stands around 500 patients for a gene therapy treatment to be profitable. And again, that is 500 patients in a market that you can sell to. And so if you expand globally, that might translate to 1,000 or 1,500 patients globally, right? And so this was completely unacceptable for me. So I took my matter in my own hands. I started a foundation. We raised about $500,000, created a team of scientists, and started focusing on drug repurposing, because I felt like my son doesn't have the time to actually go build a brand new treatment. Given the severity of the disease, we wanted a treatment today. So we started about 3 weeks after his diagnosis. We started him on 3 different supplements. And after just about 48 hours of being on a mild dose of a drug called N-acetylcysteine, we saw some energy improvements in his body. And since then, we have tried 6 different treatments on him. 4 of them are supplements. 1 of them is an experimental treatment that we had gotten the FDA approval for. And the last one that he's currently on is a off-label treatment. It is an asthma drug that we had repurposed for his condition. It's too soon to say, but we are seeing some positive improvements with the asthma drug. So fingers crossed that this pattern will continue. But still, all of his challenges that he started with when he was born still continue. He is still not able to walk, talk, eat anything by mouth. And in fact, we think his disease is progressing a little bit faster than we anticipated. But, Raghav is not the only person, right? As you all know and are very well familiar with, there are 400 million patients in the world suffering with rare diseases that just affect 10 patients, like 100 patients, 1,000 patients, too few for any biotech company to care about. And if you take all of these patients and put them in one country, this would become the third largest country in the world. And half of the patients in this country are children. 95% of these diseases don't have any treatments at all. And this was just completely nuts, because with the rapid decline in genetic sequencing cost, more and more people are going to get diagnosed with rare diseases. I was just talking to someone yesterday that said there is another study that's now expecting that there are more than 10,000 rare diseases, more than what previously was even assumed to be. And I think as more sequencing continues, as more research continues and classification continues, we are going to find a really long tail of rare diseases that affect too few patients, right? If you combine all of them, they are going to be a substantial number. But from the biotech company standpoint, companies that tackle a disease by disease or disease by disease basis, they are not going to find a sufficient market for them to go invest in drug development. And so since last March, I have been asking this one simple question to a lot of people. I've asked over 200 experts this question of how do we bring treatments to all rare diseases such that no patient like Raghav and your kids are left behind. I've asked researchers, C-level executives, large public biotech companies, insurance providers, FDA directors, and patients. And unfortunately, there is just no simple answer to this question. The question seems fairly simple and obvious, and a question that we all are asking every single day. But unfortunately, the answer is not obvious because the treatment development ecosystem is a really, really complex maze. Starting from patients to researchers to biotech companies to insurance providers to hospitals, regulators, everybody is playing a part in this ecosystem. And adding to the complexity, the biology of most of these diseases is just a complete mystery. And so we need many scientific and business model breakthroughs to make rare disease drug development economical. But these folks told me that if we foster open collaboration and hopefully lower the cost of drug development, and more importantly, operate at a global scale, we should be able to have a chance at getting treatments to all of these patients. And from my experience and my background, I realized all of these properties are typically what open source software would satisfy. So with a few of my friends, I started Open Treatments Foundation with a mission of creating a society where there is at least one treatment for all genetic diseases accessible to all patients worldwide. Obviously, this is an incredibly lofty mission for one or a few people to actually handle, but I realized there is a difference that I can make here. I don't have to actually create all of the treatments to others. I can create a society where others go create treatments for folks. And so my focus is on solving some of the more fundamental problems that are preventing us from getting to treatments. And I'll talk about what our strategies are in a minute. We launched Open Treatments Foundation last year. It was fascinating because we started with a problem of helping other patient foundations building gene replacement therapy. And in about 2 months after we built that platform, we realized this was a wrong problem to go after. And so we scrapped that and pivoted and then started working on something that's a little bit more fundamental. And we got funding from the Chan Zuckerberg Initiative to go build this platform that counts the number of diagnoses for all rare diseases across the world and displays them in a publicly visible dashboard. And so my question of how do we bring treatments to rare diseases now then transform to how many patients do we have for all the rare diseases? Now, that answer should be quite simple, right? Because if you have a kid with a rare disease, they had gotten their diagnosis somewhere. It's not a mystery where they've gotten it. They've probably gotten it from some genetic testing company. And so if we get the data from all of the genetic testing companies and aggregate them, we should be able to display the counts of number of diagnosed patients per rare disease across the world in a publicly accessible dashboard. That's the current problem that we're focusing on. But our higher level strategy is that I want to put every disease in the map. And this is the first step towards doing that by displaying the counts of diagnosis. The second step is to make the diseases quite easy to work with. And this is exactly what you all are doing with your natural history study and other research initiatives by giving the tools that are so fundamental for drug development and making them available and accessible to everybody that needs them. The third strategy is obviously getting more money for research because there's nothing that happens without funding. And we're not talking about small amounts, we're talking about lots of funding, right? And we need to create a more sustainable way, either through crowdfunding or some incentive-based funding mechanism to generate more money for research. And lastly, and this is the part that I'm actually more excited about, is creating more drug developers. Everybody sitting in the room, in my eyes, is a drug developer, right? You are playing a part in helping build a treatment, and you should call yourself a drug developer. It's not only the student C-level executive sitting in some boardroom that should call themselves a drug developer. Every mom and pop needs to be one, and that's another big part of my mission. And this last one turns out to be more of a personal mission than simply an organizational strategy. Because I've also started a different initiative now called CuresDev that I'm focusing on helping educate patient leaders like you with courses and case studies and materials to help you become a more robust, more successful drug developer. These strategies actually something that I created about a year and a half ago. And turned out that every part of my work is defined by the strategy. And I am able to see other pieces of the ecosystem that also fit into this strategy. So even though Open Treatments is a very small, focused nonprofit organization, I think this strategy will work essentially for every organization. And so this could be TANGO2 Research Foundation strategy too, except that you don't have to focus on all diseases. You can take the same strategy and apply simply to TANGO2. And I think you will be successful in your own scale. With that, I'll stop. I can be reached at any time with my email or on LinkedIn. But if you want to talk more, feel free to reach out and I'm happy to chat more. And I'll take questions now.
Thank you, Sanath. Yeah, just open it up. If you would like to answer any question, ask any questions, you can unmute. Is that correct? Kasha, that everyone's able to unmute themselves?
Yes, I believe so. How old is your son now, Sanath?
He is going to be 4.
I can imagine his birthday celebrations are wonderful, huh?
Yeah, we have mom just showed me a big list of things to do today to prepare for his birthday celebration.
Sanath, I do have a question about you had a couple of your key targets, and one of them included the idea of incentive-based funding. Could you elaborate on that? Yeah,
so right now the way the biotech ecosystem is incentivized to fund is to maximize shareholder profit, period, right? So if you need to start a new drug development initiative, you probably have to go to a venture capital firm and raise $50 million or maybe $100 million. It's the sum of money that is too big for any individual or a nonprofit to be able to raise. And at that level of funding, their incentives are double my money, right? And it's unfortunate, but as the company matures through the drug development stage, they eventually go public, and the incentives of a public company are to maximize shareholder benefit. And these incentives don't directly align with the incentives that we have for our kids, which is finding treatments. And so there are other incentive-based funding mechanisms that might work and that might hopefully de-risk some of the drug development. One of them, and most of these mechanisms are in the repurposing space, where the cost of drug development is quite low. And so one of the incentives could be, well, you get to have some more exclusivity over some of the treatments that you get. And therefore your funding essentially is based on that exclusivity, which we have patents today, but patents don't really protect against repurposing for generic drugs. And so these are incentives that are not currently available in the market today. They can't really create them too, but we need the ecosystem to go create some of these incentives. There's another type of incentive, which is, I guess it's not quite an incentive, but it's a business model. It's a cost plus business model where you always charge no more than 20% over the cost price of your drug, right? So if your drug costs $1 million, you cost $1 million plus 20%, and the 20% is your profit margin for doing other things. That business model is currently being, popularized in the pharmaceutical space. Like Mark Cuban started a company famously for this particular type of a business model for delivering drugs, and it works quite well. And so we have to really explore some of these creative and quirky approaches to actually funding drug development, in hopes that they would create more sustainability and not just maximize an individual's profit.
Thank you.
Of course.
If no one else has questions, I'm sorry guys, but I do have another one. It's actually more of a personal question, and I think a lot of us in the TANGO2 community would relate with the complexity of diagnosis. And it was that you said it was around 1 year for you to reach diagnosis. And I just was curious, what was the penny which dropped? So how did your doctors come to that diagnosis at a year?
Yeah, so we had gone through a sort of 3 misdiagnoses up until that point. And so first of all, we didn't care about a diagnosis for the first 3 or 4 months, because life was so hectic that we were like, I'm battling to keep my son alive, right? And once he stabilized, then we started taking him to different specialists at that point, who started thinking about diagnosis. And the first sort of sign of diagnosis started after we figured out a particular bone abnormality that he had. And so our doctors did assume it was a particular type of an abnormality. They did a targeted genetic sequencing with a panel, and then they did a targeted gene-specific sequencing, which both of these turned out to be false. And then they expanded into a whole genome sequencing, which gave us a diagnosis that we currently have today. So it's we could have gone to the whole genome sequencing and cut the chase, and we would have saved about 6 months.
Yeah. But yeah, obviously very important to keep your kid stable in the start of his life. It takes precedence.
Exactly.
No, but I feel like a lot of us in the TANGO2 community is a similar thing. I was fortunate that my neurologist put it on the gene panel, so we didn't have a whole exome sequencing, but it's the story, a very common story for a lot of the patients for TANGO2. The last question that I had was just to get clarity on the name of your newest initiative.
Mm-hmm. So it's called curesdev.com, curesgev.com. I'll put it here in chat. It's something that I just started recently, like 3 months ago. We did one course of the drug development, one cohort of the drug development course in June. I'm doing another cohort in August. And so if you're interested, feel free to sign up, and I'll probably open up another cohort at some point down in the future. But I'm also trying to make this more accessible to anyone, so it doesn't have to be a live course. I'm recording a lot of these and posting, eventually we'll post on the website. And I'm also building some tools that could hopefully simplify your life. For example, I was listening to your ask to the community about reconsenting, and I just thought, this should be a tool available to all of us, and you don't have to be emailing a bunch of people and getting a PDF and walking through signing those things, right? And so I don't know if I will eventually build a tool for reconsenting, but these are the sort of small, simple problems that no one will really care about that I care about.
I appreciate
Are there any
that
other
thinking.
questions?
I have one more question too. Can you tell a little bit more about the project you're doing with the CZI grant?
Yeah, so the idea is quite simple. We should be able to display the counts of number of patients getting diagnosed per year on a public accessible dashboard. This data is not sensitive. This data is not money making for anyone, any institution. And quite honestly, this data should be available as a social infrastructure. Because if you have this available, then underdiagnosis across the spectrum, and so you can hopefully advocate for and invest in newborn screening. This, more importantly for me, now biotech companies and our drug developers have access to more diseases that they can potentially work with. So let's say if a company is interested, or if their business model is suited for working with a 100-patient disease, and they have almost gotten successful with one 100-patient disease, they can now look for other nearly the same size of diseases and go start working on them, right? And that increases their portfolio, and that obviously increases treatments that get to the market. And if none of these diseases eventually get treatments or have someone working on them, then that's something for the NIH to maybe go fund research and actually go invest in treatment development for them. So all of the conversations around the rare disease ecosystem currently is based on hypotheticals. It's based on estimates of 7,000 rare diseases, estimates of 400 million patients, right? Well, I don't care how you classify the diseases or not, but I do care to count the number of patients we have, and that should be available. And so ultimately, the goal is, if you go to Google, and today if you type COVID cases, it shows you a nice chart. And tomorrow, if you type rare disease cases, it should show you that nice chart with some drop downs by rare disease.
Thank you.
I have a quick question if we have the time. First of all, thank you. That was really interesting. One of the things that I've been thinking about since our conference in Orlando is that the attack seems to be focused on individual rare diseases. And what seems appealing about your dashboard is that eventually, as more of these rare diseases and successful, maybe not treatments, but like our vitamin B discovery type things, as those things can be plotted and shown on something like a dashboard, it may be that these individual rare diseases start looking less individual and can be lumped and perhaps be more appealing as a group to get more interest in something that is lumped together rather than there's 10 patients here and 100 here. It might be that a number of these rare diseases can come together and start looking like there's some link here that can be solved as a group rather than individually. Is that part of your thinking going forward on the dashboard?
Precisely, but I won't be doing that. I will be looking up to the ecosystem to be doing that. And so that's sort of the difference in what I'm doing is I solve the problem that's so fundamental, but really focus on that problem. But then as a side effect, a byproduct of solving that problem, it opens up the ecosystem to be able to do a lot of these things. And speaking of combining diseases and working on them, I think this is another deficiency in the current biotech ecosystem thinking. When we think about treatments for diseases, the prevailing thinking is you have to have a target for your drug. And a target is generally something that's so specific and clear, and is generally associated with the disease. And that is how the biotech focuses only on a disease by disease basis, because your funding essentially, your passport to funding is tied to the target that you're attacking. When we start combining diseases, we will find lowest common denominators that won't generally have a target, that won't be as sort of sexy and new as like a gene therapy or a CRISPR, right? But that will be as simple as a vitamin D. Like my son is on a high dose of vitamin E, right? And it costs nothing. Insurance would cover it. Not a lot of companies can make money on it, but these are the sort of discoveries that I think is going to happen as we start combining diseases. So again, going back to funding models, we just don't have that structure and incentive set up to be able to combine diseases and discover these lowest common denominators that may or may not make a lot of money for a company.
Sanath, I do have a question as well. Thank you so much for sharing your story and your vision. It's amazing. Currently right now with your community, the GPX4 community, you said your son is currently doing a couple different treatments right now. Is the community doing the same? And has there been any breakthroughs for your community right now?
My community is too small. So the 10 patients that I know of are, I actually know of 3 patients myself. I can talk to them, but the remaining are scattered around the world. They were reported by a Japanese researcher who couldn't give me the names or contacts of these people. And in some cases, these are folks that don't speak English, that are not in a state of even being able to think about drug development and so on. And so the other 2 kids that I know of, one of them is in San Diego, another one is in India. They are essentially following what Raghav is doing to the most part. We haven't seen any breakthroughs in them. The drug that they haven't started yet is the new asthma drug that I'm repurposing. So I'm hoping to work with the San Diego doctor to start that soon on those kids, and we'll see what happens there. It's also kind of challenging because it's a neurodevelopmental disease, and so it's not degenerative in the sense that he didn't lose skills after he was born. He never was born with some of those skills, and so it's hard to see what would happen if we sort of remove the blockers that were slowing his development. And that's where the natural history really helps. And I wish I could collect natural history, but these number of patients that are this too scattered all over the place to collect natural history. So in an ideal world, if I had a robust natural history, then I can very clearly say, oh yeah, my son's doing better than the natural history. That's how I would go about doing that. Unfortunately, we don't have it.
Thank you.
Sanath, I was interested in knowing what the name of your podcast is.
It's called Raising Rare. Let me put it here.
Gotcha. Thank you.
Yeah, I've got a question for you, Sanath. I'm curious with a disease like yours, where there really aren't an awful lot of patients. I would also have to imagine that there hasn't been an awful lot of research done up to this point. Would you talk about how it is without like a great understanding of the underlying like mechanisms of the disease, how it is you were able to kind of identify potential a drug for repurposing?
Yeah, that's a good question. Fortunately, there were a couple of people that were working on this from a cancer science standpoint. And so the cancer drug essentially, so they get the gene is crucial for cancer, and in some areas. And so someone has been working on it, and I reached out to them, convinced them, and have them start working on my son's disease as well. So the first thing we did was create fibroblasts and some cellular models for my son's disease, and that helped them go develop an assay for it. So they essentially took the assay that they had already built for the cancer treatment and tried it on my son. And that assay also worked on my son's disease. And so that was sufficient for us to go do some more scientific investigation and find these drugs. Out of the 6 drugs, 5 of them were things that I found online by researching and looking at sort of connections between my son's disease and other closely related diseases and the drugs that work in the closely related diseases. And so we could reuse some of that work that has already happened elsewhere.
Awesome. And just a follow-up. So what was the process with the FDA to get off-label approval for that?
Mm-hmm. So the off-label treatment didn't need an FDA approval at all. Okay. Our physician could write a prescription directly. I did go through an experimental treatment that needed an FDA approval. It's called compassionate use or single patient IND. And there's a paperwork that you fill out and you submit an application to the FDA asking them to authorize emergency use of this treatment because my son's condition is so severe and we believe this treatment could help him. And that's how we got them to try that experimental treatment for about a year. But I don't think that did anything for him at all.
Thank you.
Of course.
Okay. Thank you, Sanath. I just had one little anecdote. When shortly after my son was diagnosed with TANGO2, and I was a little bit lost, as we all have been. I'm a teacher, and we had an assembly at my school, and we had like a guest speaker, and it was actually a pretty cool guest speaker. He was I'm not sure in America if you have heard the story of the Thai soccer team that got lost in the cave.
No.
I think it is they're making it, there's a movie of it being released on Amazon Prime, I believe. In any case, we had one of the rescuers for the world's greatest cave rescue, and his name was Craig Chellen. And he said that, he's just a cave diving expert, and you accumulate a whole bunch of random skills throughout anyone's life. And he sort of said that he always had this sort of belief that one day every person will just encounter some sort of challenge, regardless of whether they're prepared for it. And all they can do is just throw all of their abilities and forces at that challenge and see if they can make it move. And your story just reminds me of that so strongly. It's just a guy that knows a lot about programming, knows a lot about software, and deeply cares for his son and sees this as his challenge in life. And I think that's inspirational. So thanks so much for sharing your story with us.
Thank you. Thank you so much for having me. It was great talking to you all, and thanks a lot for all the great questions. If you ever want to talk to me, reach out to me via my email. I'll leave them here in chat.
And thank you all for joining us on the TANGO2 Talk. The purpose of the Outreach Committee is to reach out to families with new information and to make connections. But we also want you to reach out to us. It goes both ways. If you ever have any questions or want to find out more or volunteer or fundraise, just reach out to any of us who are on the Outreach Committee. Or if we're part of the TANGO2 Research Foundation, we'll be happy to help you out. Look for the next TANGO2 Talk in November. Thank you, everybody, for attending.
Thank you.
Bye.
Good to see you all.
Good to see
Bye,
everyone.
everyone. Good seeing you guys.
Thank you very much.
Thank you.
Enjoy the rest of the
Nice
weekend.
seeing you.
Bye-bye.
Weekend.
Bye.